Uh, Good afternoon. Dr. Rishi Swarup needs no introduction. So he's a young star himself, and he's a medical director and chief surgeon at the Swarup Eye Center, Hyderabad. He has numerous achievements and awards to his credit. And I think we'll hand it over to him and hear from him. Over to you, Dr. Rishi.
Thank you, Dr. Parikshit. At the outset, I'd like to thank the AIOS Scientific Committee and particularly Dr. Somshila for involving me in this first webinar from the Scientific Committee, and it's good to be in such august company. I'll just get started with my case. So it's an interesting case which I had managed a few years ago, and Dr. Somshila wanted me to present a case on this topic, so I selected this one. Just one second. Yeah, is my slides visible?
Yes, yes, it's visible.
Okay. So this was a 65-year-old female patient who presented to my clinic in November 2011. She was a case of advanced rheumatoid arthritis who was already on systemic treatment with recurrent episodes of corneal melts in the past. And she had also presented with complaints of history of viral keratitis in the past, which was documented. And she had, came to my clinic with complaints of blurring and burning of eyes. And she had all the classic systemic features of rheumatoid arthritis, the hand deformities, and both multiple joints of upper and lower limbs, and also had dryness of mouth. Her vision was 6/18 in the right eye and 6/9 in the left eye. And she had a few SPKs in the right eye and a lot of SPKs in the left eye with peripheral thinning. Surprisingly, the vision was better in the eye with more SPKs. At this point, I don't remember why that disparity was there, but this is what is documented in my file. The Sharma's was 4 millimeters in the right eye and 1 millimeter in the left eye, Sharma's 1, and the rest of the ocular examination was within normal limits. So the patient was put on preservative-free lubricants and topical cyclosporin, and was referred to the rheumatologist to look at her systemic status. And over a couple of weeks, she improved and she became comfortable and was asked to continue drops. Of course, I gave her the option of punctal occlusion, etc. But then the patient came back in December with decreased vision and redness of 2 days duration. And she had an atypical epithelial lesion, like a heaped up epithelium with the underlying stromal infiltration and edema, which kind of looked like somewhat like a viral keratitis. Her corneal sensations were also reduced. And since she had a past history of viral keratitis, I made a provisional diagnosis of viral keratitis, but the differential diagnosis of a rheumatoid melt. I started on topical antiviral, but also started her on steroids because she had an active stromal infiltrate, along with the lubricants, of course. And she responded to this treatment and resolved within a week. Then again, in the subsequent year, March, July, she came for a routine follow-up and she was doing okay, and her vision also had improved in the left eye. So she was on topical lubricants and cyclosporin. Then in September the same year, she came with another recurrent dendritic keratitis, which was treated with topical antivirals. And then she got okay. At this point, I started her on a prophylactic oral acyclovir 400 milligrams twice a day also. And then the patient got back to her old status and she was doing okay. And again, 1 year later, after this was September, and then August 2013, she presented with another acute episode with drop in vision, and she had an inflamed eye with an acute corneal melt. This time it was looking more like a rheumatoid melt. This patient was essentially put on steroids along with lubricants. And of course, I sent her back to a rheumatologist to step up her systemic treatment. And she again stabilized. And for over a year, she was okay. Then in Jan 2015, she came with a drop in vision in her left eye. And right eye pretty much looked the same, but left eye basically showed an increased cataract. And rest of the findings were pretty much the same. She had a stable ocular surface. And of course, there was the old scar and thinning from the last episode of melt and also the previous scars. The topography showed a fairly regular astigmatism, which I'll be showing later. So since I was planning a cataract surgery for this patient, I decided to go with a toric IOL. This is what the patient's cornea looked like. You can see the scarring, and there's a lot of thinning with vascularization, almost 80–90% thinning, as you can see in these images. And the cataract was about grade 2 nuclear sclerosis. You can see on the OCT that that area was, the stroma was quite thinned out in the area of the scar. And the topo, you can see that there is some irregularity, but there's not much of skewing of the Myers. The bow tie is pretty much in line. So I found that these patients often do well with toric IOL. So that's what I decided to do in this particular case. I'll show you the video later when we are discussing. And of course, there were some challenges with visualization, but we managed to safely implant the toric IOL in the desired axis. I used a Technis toric IOL because that was pretty much correcting what I needed to correct in this particular case. And this is how the patient looked the first post-operative day. You can see that the IOL is in place. And luckily, the vision was pretty good, 6/9 unaided, improving to 6/6 parts. And you can see that the IOL is perfectly aligned with the planned axis that was desired. And subsequently, this patient also underwent right eye cataract surgery. The right eye was the better eye in 2017. And even 4 years later, the patient maintained pretty much the same cornea with similar visual outcome. So just to show that even in challenging cases, one can use toric IOLs and get a good outcome. So there were a lot of points to discuss in this case. One was, how does one differentiate a rheumatoid melt versus a viral keratitis? And are these two conditions described in literature to be associated? Whether topical and systemic immunosuppression would have predisposed to the viral recurrence, and what should one be doing in such cases, including the systemic immunosuppression and topical cyclosporin. Cataract surgery in such eyes with bad surface, scars, what should one do? When is it the right time to operate? Should one put temporary plugs before doing surgery? What is the role of prophylactic acyclovir and how long should one give it in such a case? Biometric challenges, etc. How to select the toric IOL, etc. So I think all these points can be discussed, and I'll now hand it over to Dr. Somshila to take it forward.
Thank you,